Hi, good morning. Welcome to this ICER convened meeting of the Midwest Comparative Effectiveness Public Advisory Council on Tezepelumab for severe asthma, its effectiveness and value. We'll be starting in about 1 minute, so just hang on. We're letting other people join the webinar, but we'll start shortly. Thank you.
Hello, everyone. My name is Reem Mustafa. I'm an associate professor at the University of Kansas, and I will be chairing this meeting today. At the beginning of every Midwest CEPAC meeting, we want to ensure that all speakers disclose any financial relationship with industry. Every member of our Midwest CEPAC panel who is present today has met the ICER conflict of interest policy. So I would like the members of the Midwest CEPAC to introduce themselves, their work, and note whether they have any updates to their declaration. I'm going to start by myself. As I mentioned, I'm Reem Mustafa, and I actually do not have any related conflicts of interest. Next, I would like Dr. Eric Ambrecht to introduce himself.
Hi, my name's Eric Armbrecht. I'm a professor at St. Louis University School of Medicine. I have no conflicts, but do disclose that I serve the state of Missouri's asthma program as an evaluator and am supported by funding from the Center for Disease Control.
Great, thanks, Eric. Dr. Alan Balk.
Hi, I'm Alan Balch. I'm the CEO of the National Patient Advocate Foundation. I have no updates. Thank you.
Great. Dr. Kurt van den Bosch.
Good morning. I'm Kurt van den Bosch. I'm a pharmacist with the St. Luke's Health System in Idaho, and I have no updates on conflicts of interest.
Great. Thanks, Kurt. Angela Brown.
Good morning. I'm Angela Brown, CEO for the St. Louis Regional Health Commission, and I have no conflict of interest to state.
Excellent. Welcome, Angela. Dr. Aaron Curl.
Hi, I'm Aaron Carroll. I'm a professor of pediatrics and chief health officer at Indiana University, and I have no conflicts of interest.
Welcome, Aaron. Dr. Don Casey.
Good morning. I'm Don Casey. I'm an associate professor of internal medicine at Rush Medical College with no relevant conflicts of interest or relationships with industry.
Thanks, Don. Sneha Dave.
Hi, everyone. My name is Sneha Dave. I am the executive director of the Health Advocacy Summit, and we focus on adolescents and young adults with all different chronic and rare conditions. I have no conflicts of interest to disclose.
Welcome, Sneha. Heather Guidon.
Good morning. I'm Heather Guidon. I'm the research coordinator and program director of the Center for Endometriosis Care. I'm also a board certified patient advocate. I have no updates to my conflicts of interest and no disclosure.
Welcome, Heather. Dr. Jill Johnson.
Good morning. I'm Jill Johnson. I'm a professor at the University of Arkansas for Medical Sciences College of Pharmacy, and I do not have any updates to my conflict of interest statement.
Thank you, Jill. Dr. Tim McBride.
Good morning. I'm a professor at the Brown School at Washington University, and I don't have any updates, but I disclosed that I serve on the Health Policy Advisory Council for Centene Corporation. Thanks.
Thanks, Tim. Professor Rachel Sachs.
I'm Rachel Sachs. I'm a law professor at Washington University in St. Louis, and I have no conflicts to disclose.
Thanks, Rachel. Dr. Stuart Winston.
Good morning. I'm Stuart Winston. I'm a cardiologist and a patient experience consultant at a large multi-specialty practice in Ann Arbor, Michigan. I have no conflicts of interest.
Thank you, Stuart. And last but not least, Dr. Timothy Will.
Hi, I'm a general internist, professor of medicine and public health at the University of Minnesota and Minneapolis, VA, and I have no conflicts.
Welcome, Tim. Welcome to all the Midwest CEPAC members. We're very excited to have you all and have this pretty diverse expertise around the table. We appreciate you being here with us today. I would like now to introduce the individual patients and clinical experts to introduce themselves and declare any potential conflict of interest. And as they appear on the slide, we're going to start with Melanie Carver.
Hi, I'm Melanie Carver with the Asthma and Allergy Foundation of America. Our foundation does receive funding from industry as well as the CDC.
Hello, everyone. I'm Tanya Winders, the president and CEO of Allergic Network, patient advocacy organization. And I do disclose that I serve as a speaker and advisor to AstraZeneca, Amgen, GSK, Novartis, Sanofi Regeneron, and ALK Abello. And Allergy and Asthma Network does receive funding from healthcare companies listed above for unbranded disease awareness, education, advocacy, and research.
Welcome, Melanie. Dr. Jonathan Corin.
My name is Jonathan Corin. I'm an allergist immunologist and an associate clinical professor of medicine and pediatrics at the David Geffen School of Medicine at UCLA in Los Angeles. I disclosed that I have worked as a consultant, researcher, and member of the advisory board for AstraZeneca, along with clinical research and advisory board memberships with Genentech, Regeneron, Sanofi, and Novartis.
Welcome. Thank you for being here. Dr. Michael Wishler.
Yeah, hi, I'm Mike Wexler. I'm professor of medicine and director of the National Jewish Cohen Family Asthma Institute at National Jewish Health in Denver, Colorado. In addition to my disclosures that are there, I also should disclose that I was an investigator in the clinical trials, the phase 3 clinical trials with Tezepelumab.
Welcome and thanks all for being here. And again, we appreciate your input, expertise, and spending the time to help all of us come to the best judgment we can. I'm going to ask, just similar to what we've all done, that any speaker, including the policy roundtable participants, public speakers, they all actually disclose and announce any financial relations with industry and other potential conflicts that could influence their judgment. And that information will all be available on the slides as we move on. With that, I would like to introduce Dr. Steve Pearson, President of ICER. Please, the floor is yours.
Thank you, Reem. Welcome to everybody who's watching via webcast. I'm sorry we can't have in-person meetings yet, but we're getting fairly used to this. And it's an important venture to come together to talk about these issues because it doesn't happen that often. We start off by kind of presenting, to a certain extent, the background, and it starts with why, what drives this? Why are we here today? And I'd like to start with a quote from a patient with asthma. Actually, I think this is a parent of a woman, of a child. When Julia is having asthma exacerbations, it affects her days, her sleep at night. In fact, I always sleep next to her when she's having difficulty breathing, so I can be right there to give her her medication. Asthma is the #1 reason she misses school. And obviously, the experience of living with asthma, as we've continued to learn from the patients and patient community that have joined with us on this review, it's incredibly diverse. It can strike people in their youngest age, in their older years. It can be something that's kind of chronic and steady or have really wildly differing exacerbation phases. It's frustrating and it really is a burden with a lot of yet to be conquered unmet needs. So we are here today to focus on that and to talk about the opportunities, because what we're here today is to start to talk again about the fact that new treatments are coming through. And we're going to be talking about several of them that weren't here 4 or 5 years ago to a certain extent. And what happens the day that these treatments are approved by the FDA is a sense of well-merited celebration. It's a celebration because we have a new option to help treat the patients and help their families who are still struggling with conditions like severe asthma. It's a celebration of the time, the investment, the risk of companies, certainly the investment of time and risk from patients involved in the clinical trials, clinical researchers, and an entire ecosystem that helps get new treatments from the lab, if you will, to the bedside. And so we celebrate. And along with that, we have to recognize that this, the day that the treatments are approved at the FDA, sometimes before that, people are starting to think about whether patients will or won't have access to new treatments, whether there will be issues around insurance coverage eligibility, how will that be framed, what will patients have to do or clinicians have to do in order to gain coverage. The costs are also an issue. What are patients going to be asked to pay out of pocket? And what's the influence of new treatments on insurance premiums overall? So we'll be talking about that, but it's also important to realize that we're here today partly because as we talk about the patients with severe asthma, there are others affected in the broader healthcare system who aren't in the room, who aren't on the webcast with us. And these are folks we just have to remember who, in a sense, are all of us. But some people in particular are affected very severely by the impact of rising healthcare costs. These three different people and families here in the news in different ways. Just to give you an example of the diversity here, Mr. Edlow is a pharmacist himself by training, but has really dedicated a lot of his career to witnessing and to making more visible the struggles of his community in Virginia to afford healthcare insurance, as well as the individual treatments that they come to get at the pharmacy. The Whitman family in Alaska is a kind of quintessentially American story these days sometimes of people who are self-employed, and in their state, the subsidies for health insurance on the exchange were not adequate for this family to feel like they could afford the insurance. And so they went bare, and their story is one of real stress and anxiety and health concerns because one of their kids had a concussion, and they told the story of how they didn't feel they could take him to the ER. Their daughter had other problems, and they as adults also just worried that without health insurance, they were really running important risks. And the last example is the McCoo family in Minnesota, which is, again, among the people who aren't in the room today, perhaps, but maybe they are in some way or not, but there are over 20 million Americans who today are in medical debt so severe and prolonged that they are in receivership. That means that people are trying to find them to get the money, calling them, knocking on their door. And this family has a daughter who's in the picture here with a chronic illness, whose hospital and outpatient treatments continued to rack up deductibles over the year, and they went into debt, and they continue to really deal with that debt, as many, many Americans do. So we're here today partly because we want to celebrate and the advent of new treatments, because we want to talk about the importance of that unmet need and what we can do to address it in a variety of ways, not just medications. But we're also here to realize that there's a balance that we are seeking in the healthcare system so that we can keep our eyes really right on the target here, on the patients and families, in this case with severe asthma, but that we have to remember that around them, around all of us, our families with their own health needs, with the need to be able to afford insurance and healthcare in this country. So we have to have a system that creates a whole around all of us to be able to make this work. So that's why we're here today, to struggle with some of the inevitable tensions and trade-offs that have to be talked about around pricing, value, coverage, but ultimately to do the best thing for the patients in the middle and all of us. So you've met the members of the Midwest Comparative Effectiveness Public Advisory Council. Briefly about ICER, which is the convening host for these meetings. Our support is kept updated on our website, whereas you'll see about 2/3 of our funding comes from nonprofit foundations, the chief of which is the Laura and John Arnold Foundation, California Healthcare Foundation, and several others. We do receive direct contributions from life science companies and health plans and provider groups, as you'll see, about 20%. That goes to a separate ICER policy summit and non-report activities that ICER does. And we have a small percent relatively from government contracts and individual donations. The report that's the backdrop for the discussion today starts about 8 months ago, almost 8 months ago, with what we call scoping. And that's where, of course, everybody thinks they know what asthma is. Doctors certainly do, but we start by talking to patients because we sometimes don't even know what we don't know, but we certainly know that we need to learn more about the diversity of the experience, what really matters to them about the combination of clinical effects of treatment and the broader effects that represent value to them. We speak with clinical experts, the manufacturers, and other stakeholders, and then we look very comprehensively at the evidence. Our staff go off to look certainly for the clinical trial evidence, but we're very eager to seek evidence from patient-reported outcome data, other kinds of available evidence that we can bring into the conversation about value. Part of that conversation is anchored by a cost-effectiveness model. In this case, we worked with academics at the University of Colorado. You'll be hearing from them as they present that analysis. And the whole report goes through several cycles of public comment and revision. And we're very thankful in this case to several specific expert reviewers, including Dr. Semino and Dr. Wexler, who is with us today. Now, the evidence and other material in the longer ICER report is structured in a particular way to support a broad discussion about value and the other aspects of care. And this, what we call our value assessment framework, is one way to think about that, because we often talk about the long-term value for money of treatments as something we have to try to get right if we're going to achieve that balance I spoke of earlier. So value itself is obviously a multifaceted concept. And at the bottom here, if you will, we talk about whether treatments can help people live a longer life. We certainly, in the next box, talk about whether it does lead to longer life or not. It may help us return to higher function or have fewer side effects than other treatments. You know, what can it do in a broader sense for our health? When we look at costs, we certainly look at the overall costs of healthcare, not just the drug costs. So we're looking for the potential for treatments to cost money, but to maybe help reduce costs elsewhere by reducing hospitalization or emergency room visits, that kind of thing. And then we'll also talk about and vote on things that we call sometimes potential benefits or benefits beyond health. These are things that matter to patients and to families and to society, but aren't something that you can easily capture in a clinical trial or even in a cost-effectiveness model. And then surrounding even that is, again, a set of potential social or ethical priorities around how we think about health and where we want to address the needs the most, whether there are certain ways we want to address inequities, whether we want to try to deal with the most severely ill patients and kind of capture their health and advance it in a special prioritized way. So we'll talk about all of that, and it's all in the report as a structure that hopefully leads us to a kind of a more comprehensive view of value and a broader discussion of it. Today, as we do that, we will certainly move quickly to the presentation of the evidence from the report, the clinical and the economic evidence. Then we'll have a phase of public comments and discussion. Then following lunch break, we'll come back for further deliberation and votes from the Midwest CEPAC on the effectiveness and value of the treatments. Then we'll have a short break and come back for what we call a policy roundtable. And this is where the patient experts, the clinical experts, and payers and the manufacturers will join to talk about what we do going forward. How do we interpret this evidence as it's been discussed and voted on in the context of making insurance coverage policy? How does that lead to what the out-of-pocket costs are? How do we think of what the pricing behavior and choices are that manufacturers can take to help us reach the right kinds of balance? And we'll talk about future research and the broader kind of social aspects of severe asthma that are always important and often in the background, unfortunately, but can be very, very important if we're truly talking about improving the lives and the health of people with asthma. We'll close with reflections from the Midwest CEPAC, and we will adjourn by 4 p.m. Central Time. So welcome again to the discussions today. I'm now going to hand it over to Dr. David Rinn, ICER's Chief Medical Officer, who will lead the discussion of the clinical evidence. Dave?
And I unmuted. so that I started by talking on mute so that this could be a Zoom meeting like all others. Thank you. I'm David Rind. I'm ICER's Chief Medical Officer. Next slide. My ICER colleagues on this review were Belen Hagawara and Serena Heron-Smith, and we have no conflicts of interest relevant to the report. Next slide. So asthma affects 25 million Americans, including 5 million children. It's responsible for 1.6 million ER visits, 180,000 hospitalizations, and 3,500 deaths each year in the United States. Asthma is more than twice as common among Black children as among white children and remains somewhat more common among Black adults. About half of patients with mild to moderate asthma exhibit the type 2 phenotype, and I'll be discussing that more later. And that proportion is higher in severe asthma. Next slide, please. Severe asthma has some overlap in definitions, but it makes up about 5 to 10% of all asthma. Gina defines severe asthma as a subset of difficult to treat asthma that is uncontrolled despite adherence with maximal optimized high-dose inhaled corticosteroids and long-acting beta agonists, and management of contributory factors, or that worsens when high-dose treatment is decreased. Next slide. The patient experience of severe asthma is that most patients report having daily symptoms and are scared and burdened by their symptoms. It interferes with living the life they want to live. It burdens family and caregivers. Patients fear systemic corticosteroid side effects, and daily symptom control is usually more important than reducing asthma exacerbations to most patients. Next slide. I had mentioned the type 2 phenotype, and be aware that the phenotypes aren't perfectly defined and can overlap. But in general, this involves an increase in type 2 helper cells in response to antigens and allergens. Allergic asthma and eosinophilic asthma are generally considered type 2 asthma, and all the biologics currently available are either for allergic asthma, omalizumab, or eosinophilic asthma, mepolizumab, reslizumab, benralizumab, and dupilumab. Thymic stromal lymphopoietin, TSLP, sits high up in the type 2 pathway. Next slide. And I'm going to attempt to grab control of my mouse here. Okay, and now I have that. So, and Monica will let me know if my mouse isn't visible. But you can see we have type 2 inflammation here with antigens and feeding into TSLP way up in this pathway. And that affects things like IL-4. And IL-4 is what dupilumab works on. And IL-5, which reslizumab, mepolizumab, and benralizumab affect. And IgE, which is where omalizumab is having an effect. So if you had an effect on TSLP, you'd be affecting all these pathways that the drugs we currently have affect further down. Additionally, if you look at non-type 2 inflammation, there are some ways in which there are paths that come together from non-type 2 that TSLP potentially could have an influence on. Next slide. So Tezepelumab is a monoclonal antibody targeting TSLP. It's a subcutaneous injection given every 4 weeks, and an FDA decision is expected early next year. Next slide. The scope of our review looks at Tezepelumab for severe asthma, and we're comparing it in all patients to usual care alone, generally represented by the placebo arm of clinical trials, and in eosinophilic asthma to dupilumab plus usual care. And as mentioned, we have several other biologics for eosinophilic asthma that in our 2018 review, we were unable to distinguish their efficacy. And so we chose to just look at dupilumab for this review rather than to look at all those at that time indistinguishable therapies as well. For allergic asthma, we're comparing to omalizumab plus usual care. And then in steroid-dependent asthma, again to dupilumab plus usual care, since dupilumab has an indication in steroid-dependent asthma. Next slide. Next slide. Thank you. So we have 3 trials of Tezepelumab. We have a phase 2 dose-finding trial called Pathway, the phase 3 Navigator trial in adults and adolescents with severe uncontrolled asthma, and also the smaller phase 3 source trial, which was in steroid-dependent asthma, and we only have limited reporting on that trial to date. Next slide. The outcomes that we're looking at include the annualized asthma exacerbation rate, AAER, which is the primary outcome of most trials, but actually isn't the most patient-important outcome. We also are looking at improvement in daily symptoms that the ACQ and AQLQ are these measures of, both of symptoms and quality of life. And daily symptoms and quality of life is what most patients report is most important. And the minimal clinically important difference on those scales, that is the smallest difference that most patients would consider meaningful to them, is felt to be about 0.5 points. We're interested in eosinophilic asthma versus non-eosinophilic asthma, because as mentioned, all the drugs that were for use in type 2 asthma are either for eosinophilic or allergic asthma. None of them really worked in non-eosinophilic asthma. So looking at stratification by eosinophil count is particularly important. And then we can look at allergic asthma because we're comparing to omalizumab, which is used in that subgroup as well. Next slide. So here we are looking in all patients, not just eosinophilic patients, at tezepelumab and dupilumab. Tezepelumab in that first column, you can see, is reducing substantially the frequency of exacerbations. We're looking at 70 to 65% reductions. And the overlap is pretty similar to what you're seeing with dupilumab. Then as we move over to the absolute difference in the ACQ score and the AQLQ score, and we've made both of these so that positive number is good, even though the scales go in different directions. And you can see that tezepelumab and dupilumab look quite similar on ACQ and on AQLQ, and that all these numbers are smaller than that MCID of 0.5 points. Next slide. As we move over to doing this by eosinophil count, we can see that tezepelumab on exacerbations has, again, reductions in exacerbations, both in patients with eosinophils above 150 and below 150. Their wide range below 150 is because the two trials, Pathway and Navigator, had somewhat different results, but in both trials, tezepelumab did reduce exacerbations. For dupilumab, you can see that it's reducing exacerbations in patients with eosinophil counts above 150, but really doing nothing of the sort in patients with eosinophil counts below that. And then as we go over to the quality of life measures, again, the ACQ and the AQLQ, you can see that tezepelumab has relatively similar absolute differences, whether there is eosinophilia or not. However, in all cases, those deltas are smaller than the MCID of 0.5. Next slide. When we look at exacerbations in allergic asthma, you can see the numbers for tezepelumab and omalizumab, and it looks like tezepelumab may be reducing exacerbations more than omalizumab, but the omalizumab data are from trials long ago, and it's hard to really compare the recent tezepelumab trials to these much older omalizumab data. When we look at differences in the ACQ6 and the AQLQ here, again, we see these deltas, wherever measured, are smaller than that MCID of 0.5. Next slide. In terms of reducing systemic steroids, tezepelumab was studied in this source trial that we only have limited information on so far. But we know that patients were not more likely to reduce their oral corticosteroid dose at week 48 with tezepelumab than placebo. And in fact, the point estimate of the odds ratio goes in the wrong direction, although the confidence interval is very wide. In comparison, dupilumab in the Venture trial resulted in a greater reduction in oral corticosteroid dose, a 70% reduction versus 42% reduction with placebo. More patients had a reduction in dose of at least 50%, and more patients had a reduction in dose to below 5 milligrams per day. And we usually think of 5 milligrams per day as the dose at which you start seeing important steroid side effects. Next slide. In terms of harms, adverse events and serious adverse events are rare with all these drugs. Omalizumab does carry a black box warning for anaphylaxis, And dupilumab and omalizumab have long-term safety data, which the as yet not on the market tezepelumab really can't and doesn't. Next slide. In terms of controversies and uncertainties, we lack head-to-head trials. This is, as I mentioned, particularly a problem with comparing with omalizumab. There are very high placebo response rates in randomized trials of biologic therapies. And that has a couple of issues. One, when you're getting very high placebo response rates, it may be hard to show additional benefits. And that's a concern in studying the biologics. The other thing, though, to consider is that these very high response rates in the placebo arm suggest that potentially the effect of being in a clinical trial where research coordinators and nurses are studying you and talking to you and making sure you're using your standard of care regimens appropriately really improves severe asthma a lot. And so it does raise a question of how much bang we could get by just accomplishing what is done in randomized trials to help patients with severe asthma do better with their standard therapies. Tezepelumab has a new mechanism of action, and that raises concerns about as yet unidentified harms as we would have for any new biologic. We don't have data on the subgroup who have neither eosinophilic asthma nor allergic asthma. We had asked the manufacturer for data on this subgroup, but the data weren't provided, and that leaves us with a little bit of uncertainty, although most patients do have one of those in the type 2 pathway. Again, though, we're interested in this non-eosinophilic subgroup, and we'd like to know how many of those had allergic asthma versus not. There were very few Black patients in the tezepelumab trials, despite severe asthma being more common in this population in the United States. And if we go to the next slide, and I again figure out how to request control of the mouse. You can see over here on the non-type 2 pathway, we're talking about irritants and pollutants. And we know that being African-American in the United States can be a marker for being in an urban population where the asthma might be more due to these sorts of things. And so we have some concerns that tezepelumab wasn't studied in a population where this input to severe asthma might be more important. And that's a concern for us. Next slide. In terms of potential other benefits and contextual considerations, I wanted to highlight a few. Death from asthma is uncommon, but severe asthma has daily symptoms that interfere with nearly all activities and that markedly reduce quality of life. So it is a severe disease. Asthma disproportionately affects Black Americans, and they may have a more severe disease course, so that a therapy that worked for asthma could help a disadvantaged group. And in fact, the ICER Health Improvement Distribution Index for Black Americans with asthma is 1.21, which suggests that an additional 21% of any health gains from an accessible treatment for asthma that worked for Black Americans, an additional 21% of those health gains would go to Black Americans compared to the population overall. Next slide. In terms of public comments, we received one that said the MCID concept is meant to compare a change from baseline in an individual patient or group of patients, not the difference in response between two populations. There are a couple of points here, and one I want to address is always a concern with the MCID, which is that you might be seeing a population of responders and non-responders, and you wouldn't want to think that you were below the MCID when really what you were seeing was good response in some people and no response in others, and yet you're looking at an average. The responses here in these trials suggest that that isn't what's going on. We don't have the data stratified that way, and certainly the manufacturers could have done so if they wanted to argue that a higher percentage of patients were getting past the MCID with these therapies than with placebo. The second point here, though, we disagree with. This is the notion that because there's this big placebo response that gets you above the MCID in an individual patient, that a new therapy deserves credit for that placebo response plus its additional response beyond that. And we think that misses the point of a placebo-controlled trial, which is to try to pull that out and see what you're getting from the drug beyond its placebo response. And we do think it's fair to look at the MCID in comparison to placebo. The second comment, while the report recognizes the efficacy of omalizumab for patients with an allergic phenotype, the dupilumab efficacy in this population should also be recognized. This is, of course, from the manufacturer of dupilumab. Dupilumab doesn't have an indication for allergic asthma, but the manufacturer is correct. There are recent studies showing that dupilumab does have efficacy in allergic asthma. And we just wanted to state that, even though we're not discussing that in the report, because it doesn't have the indication in dupilumab. The third comment is that ICER's reliance on the quality is of great concern, especially when being used in an evaluation regarding asthma patients. As asthma is a chronic disease, the quality of life of patients as defined by the quality is already diminished. This will lead to lower scores even for drugs that are clinically effective, as patients with chronic diseases often cannot achieve perfect health. So when we look at quality of life, we're looking at gains in quality of life. And if you have worse quality of life, you have greater room to improve. The studies that we looked at and the analyses we did are looking at changes with these drugs. And we think that the measures being used that were designed specifically for asthma are quite good at looking at this. We see that patients with severe asthma have baseline quality of life that looks like what you see in major depression and what you see in moderately severe multiple sclerosis. These people have diminished quality of life every day, and we're looking to see how much these drugs are improving that quality of life. A drug that led to very big improvements in quality of life for patients with severe asthma would be worth more than the biologics that we have today, and these measures show that. These measures are doing exactly what you want them to do. Next slide. So in summary, tezepelumab is likely effective for a broad group of patients with type 2 asthma and perhaps some with non-type 2 asthma. And that's a big deal. Again, we haven't had a therapy for patients with non-eosinophilic asthma until tezepelumab. The effectiveness, as with other biologics, reflects greater efficacy in reducing exacerbations than in improving daily symptoms. We need therapies that improve daily symptoms in severe asthma. That's not a knock on tezepelumab, but it is a reality that we need better treatments. We lack long-term safety data, which affects our evidence ratings, as it did in our review in 2018 when we rated the new biologics. And tezepelumab is probably less effective in reducing the need for oral corticosteroids than dupilumab, but we don't have head-to-head trials or full publication of source yet. Next slide. So with that in mind, we rated tezepelumab versus standard of care for all patients with severe asthma as comparable or superior. The comparable at the lower end reflects our concerns about harm and unknown harms with a new biologic, but also we're reflecting that it's providing benefits for patients who have not previously had benefits from biologics. Compared with dupilumab and eosinophilic asthma, you saw the overlapping numbers, and we rated this insufficient. For omalizumab in allergic asthma, the insufficient there more reflects the fact that the omalizumab trials are old, and we don't really think they're comparable for tezepelumab for us to really look at this and come to a definitive conclusion. And then finally, for tezepelumab versus dupilumab in steroid-dependent asthma, we rated it comparable or inferior. And again, that reflects our concern that we don't have head-to-head trials, but it looks like dupilumab works in steroid-dependent asthma in getting people off steroids, and we don't really have good data showing that for tezepelumab at this point. Next slide. Thank you.
Thank you very much, Dave. This was a very clear presentation for complex topics and multiple comparisons, really, and subgroups. I want to open it now to the Midwest CEPAC members. If anyone has any questions, please use the raise hand function. I'll try to keep track of it. And as we have the first question, Tim, please go ahead.
Thanks, David. Again, very nice job. Two questions. One, the data on the exacerbation prevention, if you could just note that again in absolute terms, one, and then two, I imagine it's speculation, but your thoughts on any possible effect interaction by race. You raise some of the biologic plausibility, but given that the results overall are negative, recognizing there's very few Black patients in there, the degree of biologic plausibility about saying, well, we just can't make any statement, and that, whether we should really consider race as an important variable. Also, given that it's higher burden in Black individuals.
Yeah, so in terms of absolute terms on exacerbations, and there was some argument about this from the manufacturers, but most patients with severe asthma, we're talking about 2, 3, maybe 4 exacerbations a year. So we're talking about drugs that might be eliminating 1, 2, maybe 3 exacerbations a year. So that's what we're talking about, and that's not, that's nothing to sneeze at. That's a big deal that you're reducing exacerbations, but these patients want to be healthy every day, and that's probably a bigger deal. On the race issue, I actually don't think there's any biologic reason to think that there are differences in asthma by race where you'd expect a different efficacy. My concern is that the triggers for asthma in an urban population are potentially different from the triggers for asthma in a non-urban population. And in the US, being Black is a marker for often an urban population. And that's my concern when I look at these data, that we may, by not having studied Black patients, not have captured that as well. I'd actually be interested in what our clinical experts think about how well we know that Tezepelumab reduces irritant, pollutant-caused asthma, given the data we have right now. I don't know if Drs. Wexler and Corin want to comment.
Yeah, I'm happy to comment on that. Actually, in a study that was published earlier this year in the Lancet Respiratory by Janet Diver, looking at Tezepelumab, there was a significant reduction in airway hyperresponsiveness with a significant change in responses to an irritant called mannitol. And so that's, I think that gets to that point. With regard to the issue of race and differences, I've published a lot on this area. There are clear differences in responsiveness to different asthma therapies in Blacks. In fact, there are also differences between Black adults and Black children. We published an article in the New England Journal of Medicine, I think it was 2 years ago, September, may have been 1 year ago only. But there are differences, and we're trying to tease out whether there are pharmacogenetic differences, pharmacogenomic differences, because there are differences that are observed between responsiveness to different therapies. With regard to Tezepelumab and race, I don't believe that there is a significant difference. I think that just the sample size is way too small to make any determination about efficacy in that patient population. I'm curious to hear what John thinks about all these issues.
Yeah, I agree with Michael that a lot of work has to be done, I think, to further define how much what we see in the African-American population is due to lack of access. And certainly there are differences biologically, but the question is, how important is that compared to lack of treatment and access and an increase in potential triggers in the urban setting, compared with, the biology. So that's a challenge that remains. In terms of looking at the effects of irritants, there was that study by that Michael alluded to, where they looked at mannitol. Yeah. And where I think that one of the issues there was to determine whether the drug actually stabilized mast cells. And it appears that there is something of an effect. There's some interesting in vitro work looking at tobacco smoke exposure and showing that TSLP is probably released by smooth muscle which is one of the sources of TSLP, in response to tobacco smoke, and that blocking the TSLP prevents bronchoconstriction in response to subsequent tobacco smoke exposure. So, there's that evidence, but I think that there's not a lot right now looking at things like air pollution. Certainly, we don't have enough clinical experience with it to look at, the epidemiology of that, look at areas with high levels of pollution and see how the drug impacts on outcomes. So I think there's some tantalizing initial data, but a lot of work remains to be done.
Yeah, thanks to everyone. I think it's fair to say that we remain a little uncertain, and that indirect evidence, while we may not have biological or pathophysiology reasons to think that they behave differently, lots of issues around access and potentially different reasons for exposure and so on. So unfortunately, Tim, not many answers, but important to raise that as an important concern.
Can I just follow up on the exacerbations? What was the mean number of exacerbations, or did they have a threshold when they enrolled them in that? It does have to do with who it might be applicable to. Sorry.
It does depend some on what study you're talking about. There were some studies that required X number of exacerbations on some of the therapies, but in general, we're talking in the trials at baseline 2 to 3 exacerbations per year.
Yeah, in the Tezzy studies, it was 2 exacerbations per year.
Right, and dupilumab only required 1.
Okay. I'm not seeing any other questions, but I actually would like to invite our patients to just comment. So I'm struck by this very important point that comes up clearly, and David presented clearly about the fact that patients viewed improvement in their daily symptoms to be more important than the decrease in the exacerbation. And again, not to minimize that the decrease in exacerbation is really important, but can one of the patients or both comment on that?
Sure, thank you. Tanya Winders, Allergy and Asthma Network. Definitely, I would suggest that what we hear from patients is that exacerbation is relatively rare in the grand scheme of things. Even in severe patients, they're not frequently going into the hospital or having those repeated ER visits. And so it is that daily quality of life. How do we reduce symptoms so that they can go about being people, not patients, fulfilling their responsibilities as mothers, daughters, sisters, friends, and going to work, and certainly doing all the normal activities of daily living.
Thank you, Tanya.
And I would echo that as well, Melanie. Severe asthma can be incredibly debilitating to complete even simple tasks. Sleep, with traveling, meeting up with friends, issues at work go beyond just missing days of work, but being productive at work, having either your sleep impacted or just struggling to breathe can impact your productivity. And that, applies to school children as well. This impacts how well they learn while they're at school as well. So any improvement that people feel just in daily activities is most important to them.
Thank you, Melanie. Very helpful. Tim, I see you had another point, and I believe it was answered about the minimum important difference. That's good. Any other questions or comments from the Midwest CEPAC members?
If we don't have questions actually right now, I want to answer one that Sneha had asked earlier. Oh, why don't I let Alan ask his question, and then I'll go to that after.
Sorry, this is a question for the clinical researchers, physicians, and the patient advocacy groups on the panel. How well does the quality of life scales and survey instruments that are used reflect and capture those benefits that you were describing around productivity, around getting quality days back. I realize it's different than like the Q5B. So these are specific to asthma. I'm not familiar with them, so I'm just wondering how well you feel like those capture truly what's meaningful to patients across the things that are relevant.
I'll speak up from a patient perspective. I don't think that most of the quality of life tools do fully reflect that impact on activities of daily living adequately. We know that the St. George questionnaire is probably the best and most correlated with severe asthma patients' life experience, but unfortunately, I think that the tools still are not as clearly focused on patient-reported outcomes as they are on clinical outcomes.
And I would agree with that. This is Jonathan Corn, that what we see in clinical practice, once we institute, biologic medications in really severe patients who we know are adherent because we see what their refill rate is, we know they're using their inhalers properly, and they still have poorly controlled disease. What I see in practice is that, some of the results and outcomes are absolutely astounding, how people's lives are changed. And it's interesting, certainly these are anecdotes, but I would say by and large, a large number of patients, 50 to 60% do much better with daily symptoms and quality of life, which may not be reflected oftentimes in the clinical trial data we see. So we often scratch our heads, I think, and look at clinical trial results and wonder why the subjective improvements that we see in practice with these drugs isn't necessarily, reflected. And I think part of it is when you compare with placebo, oftentimes you're taking a group of patients who may have been non-adherent. And, when you look at the placebo arms of most of these trials, they come in with an average of 2.5 exacerbations, and they get down to 1 to 1.25 at the end of the year, 52-week period, in the placebo-treated group. So you're seeing a 50 to 60% reduction in exacerbations with good adherence. What we're seeing in clinical practice is people that have been adherent. We're pretty confident of that, and we're really seeing what the drug can do. So I think they're, in some ways, even though these are validated measures, they don't always, in my mind, capture the essence of what's going on in our patients.
I agree with John. I think that what we see in real world is substantial efficacy with these therapies with regard to several domains, whether it's exacerbations, whether it's symptoms, whether it's improvement in lung function. We have some super responders who respond in all those domains, and some who just respond in some, and that's okay too. With regard to the patient-reported outcomes, they're very susceptible to placebo effect. We demonstrated that in a New England Journal paper 10 years ago in asthma, just with giving sham albuterol. People felt better. And so they're not the best tools to utilize. And even still, we see a greater improvement with the drugs compared to placebo.
Okay, well, thank you all. Important points. There are some concerns about the tools, responsiveness, but also this, response at the placebo arm is probably reflects that follow-up and all the care they receive as part of the trial is also important part of their treatment. Does not necessarily mean that they're also receiving that care in the active arm. So just something for all of us to keep in mind. I see we have more hands. So Sneha, please go ahead.
Yes, hello. My name is Sneha, and I had a question regarding the lack of evidence for adolescents in the studies, not only in terms of efficacy, but also safety profiles of it. And so I wondered if you could define what the age group of adolescents was in the study and comment on the lack of evidence for this age demographic.
Thanks. I had known that was coming, of course. So if we can go back to the slides. This is a forest plot, and you can see, that adolescent between 12 and 18 versus adult and older adult. The confidence intervals overlap, but you certainly could wonder whether the efficacy is less there. It's, it doesn't perfectly answer the question because there just weren't a lot of patients that we're talking about. We're talking about 82 patients between the ages of 12 and 18. At the bottom, you can see that when you developed asthma, doesn't seem to have had any effect. It didn't matter whether you developed it as a child or an adult, but that isn't really what you're asking. You're asking, does it work as well in adolescence? And there's been a general belief that the biologics, a lot of the studies just combine these groups together. And I went to look to see whether anyone had really done a systematic review looking at the 12 to 18 group versus the older groups across all the biologics, and I couldn't find one. I don't know that I can perfectly answer for you whether these drugs work equally well. They do seem to work. I don't think that 30% reduction is nothing. And it might well, given the overlapping confidence intervals, be identical to the older populations. But there are some other very small numbers in a couple of the other trials that have been published where, again, the adolescent population may not be getting as much benefit. In terms of harms, there were very few harms found in these trials compared, for many of the outcomes, placebo was doing worse on adverse events than Tezepelumab, other than injection site reactions. So, it's not that we have so many adolescents that we can be sure, but I don't particularly have greater safety concerns in the adolescent population than in the adult population. You could imagine reasons that either population, depending on the side effect you're worrying about, could be at greater risk.
David, if I could comment, I think part of the answer with adolescents, in addition to the small sample size, may lay in, if we go back to that whisker plot, so you can see that in the adults 18 to 65, that you've got in the placebo group 2.27 exacerbations. And this is, I think, based upon the fact that people came in with greater than 2, and then you see the improvement on active drug. In the adolescent group, you also came in with greater than 2, but during the placebo treatment arm, you can see 0.97 exacerbations. In the active arm, 0.66. So I think, or 0.68. Part of it, I think, is when you get adolescents who are notoriously non-adherent to inhaled therapies, and you put them in a clinical trial, as Reem said, with lots of care, lots of support, they do much better. So I think part of the difference is that the placebo-treated patients did amazingly well with a much larger reduction in exacerbations compared to their baseline during the year prior to entering the trial. So that, I think, does color this data to some extent. That may be part of it.
Thanks.
I think it's a sample size issue. And we've done other studies in which we've compared adolescents to adults and adolescents to younger kids. And the adolescents more closely resemble the adults. They're almost identical in terms of response in other studies.
So Mike, can I just ask on that? When I was looking at that study, that seemed to be for non-biologic therapies like LABA and inhaled steroids.
Yes, that's correct. That's
Okay.
right. So yes, we can't necessarily extrapolate to biologic therapies. There are, although, we know the recently published Dupilumab pediatric study showed almost equal efficacy in pediatrics in general compared to adults. We've seen the same thing with omalizumab and mepolizumab as well. And so the efficacy seems to reflect, although again, we're not in the same study, but in the pediatric studies, we're seeing very similar kinds of results in those patient populations.
Okay, that is very helpful. Melanie, I saw your hand was raised earlier. Do you still have something you want to say? That would be our last comment before we move to the next presentation.
Yeah, so just circling back to the quality of life issue and the evaluation tools we currently have, some parts where they miss the mark is adequately capturing the mental health component. We did a survey a few years ago, and 78% of people with severe uncontrolled asthma say that asthma is always on their mind. and the emotions and feelings that they have overwhelmingly are fear and isolation. And that is something that they're dealing with on a daily basis. And then I also wanted to circle back to the issue of the lack of diversity in the data. And when we're comparing even to the other treatments, I think it's important to acknowledge that none of the drugs have had adequate representation in their clinical trials. And so when we're evaluating these treatments and how effective they are, we have to remember the populations that have been missed out on this evaluation process.
Thank you, Melanie. Important, really things to keep in mind. And Alan, I noticed your questions in the chat. I'm gonna ask the experts and the review team to respond in the chat just to make sure that we're on time.
I was also going to suggest that could be asked if there's time with Brett, since he may be the best person to answer that one.
That's perfect. Thank you, David. Okay. I think the next is for us to hear about the evidence and economic modeling. Brett McQueen, please.
Thank you, Ree. Sorry, I didn't mean to cut you off. You can hear me okay, I assume? All right, so I'm here, Brett McQueen. I'm an assistant professor at Colorado and here to talk about the cost effectiveness of Tezepelumab. Next slide, please. Just want to acknowledge some of our key team members, also the support from ICER, and I have no other conflicts to disclose. Next slide, please. So our objective was to assess the lifetime cost effectiveness of Tezepelumab plus standard of care, which is defined as inhaled corticosteroid therapy and at least one additional controller medication. That's versus standard of care alone in patients with severe asthma. Next slide. Next slide. We're looking at this from a lifetime horizon, and the perspective is healthcare sector. So direct medical care and direct costs, but we do have a modified societal perspective in the supplement as well as later in this presentation. Our cycle length represents the duration, approximate duration, on average of an exacerbation in terms of its impact on quality of life, on healthcare expenditures. And our outcomes, total and incremental, include costs, life years, quality adjusted life years, equal value of life years. And then we have a percent responder analysis, which I'll show and explain in a little bit. Next slide. So our cohort is reflective of the Tezepelumab Navigator and Pathway trials. These are adults that have lived with severe asthma, and they're now at the adult stage, about 50 years old, and majority are women. And then there's this subgroup using chronic oral steroids, and that's actually incorporated in the model. Next slide, please. So our treatment regimen is 210 milligrams, subcutaneous injection every 4 weeks, and we expect a decision early 2022. And I'm signaling this specifically because we're using a placeholder price. I will mention this numerous times throughout the presentation. Next slide, please. This model schematic is pretty typical of asthma modeling, fairly standardized in the field. We start with our population of severe asthma. Our intervention, again, is Tezepelumab plus standard of care versus the comparator, which is standard of care alone. And I want you to pay attention to this middle state, non-exacerbation state, because this is where the model is flexible to incorporate differences in quality of life between Tezepelumab plus standard of care versus standard of care alone. And this is going to be a key driver of the model, just to signal for the future results. From there, this is an event-based model. So we're looking at different severity levels of asthma exacerbation, all the way from mild, requiring an oral steroid burst and a decrement to quality of life, a moderate exacerbation requiring an ED visit and a decrement to quality of life, and then severe, which requires a hospitalization, decrement to quality of life, and then an increased risk of mortality. And I'm going to get into exactly how we define that in the next 2 slides. But I also want to mention there is other cause mortality included. And we're not modeling this as a progressive disease, meaning patients aren't necessarily getting better or worse. And in that way, we're allowing Tezepelumab to impact day-to-day symptoms between these 2 therapies. So next slide. Some of our key assumptions include the utility for that non-exacerbation health state. That's based on a mapped relationship between the AQLQ and the EQ5D because we didn't have direct elicitation of the EQ5D available. The increased mortality is only out of the severe exacerbation state, which I just stated on the previous slide. And we really assumed that everyone had such a severe exacerbation that they could have been hospitalized had they had the opportunity, but they may have passed prior to getting a hospitalization. So that's a really important point that flows into the model. We also include chronic OCS and its impact on costs and disutility. That's really for managing the adverse events related to chronic oral steroid use. And then we do not include switching. So this is sort of Tezepelumab. You would actually potentially have the chance to switch to a different biologic, but we're trying to isolate the value of Tezepelumab itself. So that's why we're not including any switching. Next slide, please. So this is our starting point. These are the inputs where we're really looking at the placebo or standard of care arm of the model. The top row is the annualized exacerbation rate, which is averaged across Navigator and Pathway. And you might think, you know, these are only reflective of clinical trials, but if you look at the evidence that's directly referenced below from the Chronicle study, which is a real-world observational study, the annualized exacerbation rates are actually fairly consistent with that evidence. But the difference here in the next three rows is that we're seeing the majority are steroid bursts, but there is a shift based on recent evidence, at least since we've been doing asthma modeling for a while. There are more ED visits and hospitalizations than what we observed before, which is obviously troubling. The last line in terms of severe exacerbation risk of death is really an important input derivation. We calibrate the model based on observed deaths from the CDC. We observe approximately 3,500 in the most recent year of data. Our denominator represents the severe asthma population. And in that way, we allow theoretically for Tezepelumab to avoid all potential deaths. We could instead include that denominator as all asthma patients, which really they wouldn't be indicated for Tezepelumab. That's why we're using that denominator of severe asthma. Next slide, please. And these are the inputs that are directly related to Tezepelumab in terms of reductions in exacerbations. So we see Tezepelumab doing a really good job of avoiding at any point in time an oral steroid burst of about approximately 60%. And then that actually increases for those severe exacerbations and the moderate exacerbation of nearly 80% avoiding. So it's doing a really good job of avoiding those events. Next slide, please. And these are the costs that flow into the model. I already mentioned once that we're using a placeholder price based on Dupilumab, and that is approximately 27 or 28,000. That's added to an already fairly significant amount of standard of care costs. Below that, you'll see this increasing order of costs related to a steroid burst up to a hospitalization. So you see that obviously we expect a hospitalization to be more expensive than a steroid burst, although a steroid burst is not a cheap event either. The final line, annual cost of long-term oral steroid use, again, that's related to treatment and management of those long-term adverse events. And we also include a disutility related to that as well. Next slide, please. So in order to calculate quality adjusted life years and equal value of life years, we need some sort of a health utility estimate. And like I said before in our assumptions, we use the AQLQ mapping function. And Dr. Wren shared this a little bit earlier, that there was a difference of about 0.34 when we pool across the Pathway and the Navigator trials. That flows directly into the model through that mapping function and shows up as a difference in health utility. So that's that day-to-day health state where we're showing about a 0.04 difference, which is quite significant over in the entire lifetime of patients. That's the impact of every single day on a patient's life. It's very important. And then below that, we see the increasing order, just like we saw with costs, increasing order of the severity of the exacerbation impacting quality of life. These are only applied during that 2-week duration of the exacerbation. Below that, we show an annualized lifetime duration impact of chronic oral steroid use. And that just again is about managing those adverse events that come with chronic oral use, steroid use. Next slide, please. Next one, thank you. All right, so how do all those inputs and assumptions then flow into the model? Well, I want you to start first on the far left-hand side, where we have at the placeholder price of the net pricing of dupilumab, we're showing tezepelumab plus standard of care increases our intervention costs over standard of care alone, but then that comes with cost offsets. So remember the rate ratios that are reducing the chance of mild, moderate, and severe exacerbations. That's showing up as cost offsets in that other column, the other non-intervention costs. Still, we see based on the net pricing of dupilumab as a placeholder, there would be an increase in the health system costs related to tezepelumab plus standard of care. And that comes with an increase in health benefits across quality adjusted life years alone, equal value of life years, and then this percent responder, which I haven't defined yet, but there's a study that came out showing differences in the ACQ. So David spoke a little bit about this, of at least 0.5 at about 1 year. So we're seeing this 12% absolute difference in terms of an increase in the percent that respond. And then we include that over a lifetime with the total costs. Next slide, please. So these are our base case incremental costs. Remember, we're looking at tezepelumab plus standard of care using a net price of dupilumab versus standard of care alone for a cost per quality gain of $430,000. That is slightly reduced when we look at cost per equal value of life year gained down to about $420,000. And then the cost per responder is higher. It's 4.7 million. And the reason why is because we're treating it as one event at that 1 year time point. And that's really important because we're not accruing benefits of the treatment on quality of life over the full lifetime. So that's why there's such a big difference between those two estimates. Next slide, please. So this is our one-way sensitivity analysis. And just to remind you, each input is varied while holding all other inputs constant. And then we're trying to view the impact on our base case estimate. So the vertical axis is set to the 430,000 per quality adjusted life year, again, using the placeholder price based on net pricing of dupilumab. You'll see the range goes all the way from 300,000 up to 600,000. And as we would expect, the utility for the non-exacerbation state is going to be a really significant driver of our results. We would expect day-to-day symptoms to impact the model as a great deal of variation. The next one, severe asthma, exacerbation risk of death. The lower input for that, or excuse me, the higher input for that is based on only if we assume all deaths flow through hospitalization. So that reduces down to about 300,000. So it gives us kind of a window of how much severity severe asthma exacerbation risk of death impacts the model. The other drivers include, of course, the treatment effect and the starting point, the annualized exacerbation rate, which are also key drivers. Next slide, please. So what if we varied all of those inputs, including others at the same time, and repeated the model over and over and over again, and then calculated the proportion that would meet these commonly cited cost effectiveness thresholds? That's what we're doing here. So on the top table, you'll see we didn't observe any that broke the 150,000 commonly cited threshold per quality. And then in the bottom table, we're using equal value of life year gained as our outcome. We also observed none of those simulations reached the commonly cited cost effectiveness thresholds. Next slide, please. So I spoke a little bit about the modified societal perspective, and this includes an analysis from the Nationally Representative Medical Expenditure Panel Survey. It was a paper that just came out that described differences in missed time at work as well as missed time at school, and in a sense, costed that out per year. And you see that the cost per quality gain actually reduced slightly, as well as the cost per equal value of life year gained, because we're offsetting some of those costs based on the impact of tezepelumab plus standard of care. And again, this also uses the placeholder price of dupilumab. The estimates did not achieve commonly cited cost effectiveness thresholds despite these reductions. Next slide. So we have a few limitations. I think I've said a few times that we're using the placeholder price for tezepelumab based on net pricing of dupilumab. We don't actually expect the prices to come in a lot lower, mainly because there's sort of a clustering of net pricing around asthma biologics. The second point, we wouldn't really expect long-run evidence on response and discontinuation. Therefore, we assumed full adherence and constant treatment benefits over a lifetime. We didn't observe direct mortality in the trial. So there wasn't actually a rate ratio. Remember, I shared the rate ratios on exacerbations. There wasn't one for mortality directly. So I think there is some future evidence that's needed on some of the indirect mortality estimates. And some of that came up in the public comments, which is on the next slide. So that's the first point here on the comments received. Mortality risks, of course, can occur outside of hospital settings. I think I said earlier that really our assumption is patients had an exacerbation so severe that they would have been hospitalized had they had the opportunity, right? So it's not that we're assuming patients can't die out of hospital settings. It's just the way our input derivation actually allows for tezepelumab to avoid all of those deaths. I think further evidence is needed in that area. There were requests for comparisons to the 2018 review, and we think it's inappropriate to compare, mainly because there's a lot of new evidence in asthma that has been produced over the last few years, making the comparison really irrelevant. In the final point, we did make some changes to the clinical and utility inputs for omalizumab and dupilumab. For those of you who don't know, in the supplement, there's actually scenario analyses in those subgroups of eosinophilic asthma as well as allergic asthma. Next slide, please. I think that might be questions. Oh, excuse me, conclusions, of course. So the first point, tezepelumab, as we saw in the base case results, plus standard of care, provides clinical benefit in terms of gains in quality adjusted life years, and equal value of life years over standard of care alone. However, as I just spoke about, if the price is similar and clustered around those other asthma biologics, it would not meet commonly cited cost effectiveness thresholds, and we have suggestions for that price range in the health price benefit benchmark section of the report. I think that next slide, that should be questions. Jump the gun a little bit.
Thank you very much, Brett. Again, really excellent, very clear presentation. I'm going to open it for the Midwest CEPAC members. If anyone has questions, please raise your hands. Don, go ahead.
Yeah, thanks, Brett. That was great. And I will confess I did not look at the supplement to look at the input differences between the eosinophilic and allergic, although that was my thinking in your presentation. Could you, in a sentence, summarize whether there were any marginal differences between these two without getting into a lot of detail?
Yeah, I mean, I think the short answer is that there really weren't a lot of differences in those subgroups. We're seeing a very similar trend in terms of at least cost per quality estimates using that net price of dupilumab.
Okay, thanks.
Excellent, thank you. Tim, your hand is up.
Yeah, thanks. Excellent work and presentation. Could you help me understand this price benchmark hold that's in there a little bit more? I think I understand it. You took it from the existing market price, but that's a little, I don't know if troubling is the right word, but you know, and maybe it doesn't matter much because of the numbers that you came up with. So, but I think I saw in the evidence report that you compute what the price would need to be for it to meet the health benefit price benchmark. But I don't think I saw that in your slides. Maybe you want to address that as well.
Yeah, no, it's a good question. Thank you, Tim. So we did, obviously, without FDA approval, we have to assume some price, right? Some base case estimate. And so we did take net pricing of dupilumab, so based on the information available from SSR Health, as an estimate of what the net price is, not the list price. And then from there to actually achieve the threshold. So if you recall when I had the probabilistic sensitivity analysis, how many of those simulations achieved that 100, 150,000 per quality? We're actually trying to benchmark into that price to say, what would the price have to be to meet those thresholds? And that range was about 9,000 to 12,000 when you use the range of 100,000 per quality adjusted life year or equal value of life year gained, up to around 12,000 per quality adjusted life year or equal value of life year gained. Does that help, Tim?
Yeah, that's what I read, and I just want to call it out publicly.
Great, thank you. Any other questions? Tim, well, go ahead.
Thanks. I'm not sure where I'm going to go with the question, but maybe it's coming. So thanks. That was really nicely done. And it looks like with all the sensitivity analysis, it's still all above 300,000, which maybe there's a ramble, but maybe you can comment on it. So even if you move what we consider a responder down to something like 0.25 instead of 0.5, and even if we made gigantic assumptions that blacks might somehow have a bigger effect, and about the only thing I could think of is if we go with your 82% responder and say that's the benefit, but you've got 82 versus 70, which I must have been surprised. I'm not sure where you got that from, but it wasn't from the trials. I'm just trying to, maybe I'm not even asking anything, running through any possible scenarios that might possibly move that needle, including what you said, the utility between exacerbations. I'm just worried I won't do anything because I might get an exacerbation kind of stuff. I'll shut up because I'm not sure what I'm asking.
No, I think it's a really important point, and we can go back to the drivers of the model. And I'll say again, that day-to-day symptom difference, that is everything. And I think that, as we've already heard today, that's everything for patients, that feeling like you can do things that you feel like you couldn't do without risking an exacerbation. The model and Tezepelumab does a great job of reducing exacerbations, but in the end, we really need that day-to-day symptom estimate and the difference to be bigger. And that's really what would move the needle. And I don't have an exact answer for you on that difference, but it really would have to be closer to, instead of 0.04, have to be closer to 0.2, which is a really big difference. And that's a guesstimate, but I'm actually pretty sure that that's kind of where it would have to land. So I don't know if that helps, but okay, good.
And so to McBride, yeah, so it is not a close call like you say. I think this is the point. Okay, great. Any other questions? I see Eric. Please go ahead.
Did you think, obviously the analysis is based on quality adjusted life years, and I'm just doing some back of the envelope calculations here of maybe another way that I think about this, and it's not the method that we chose, but in terms of like cost of exacerbation avoided, right? And that, to think about this as like, well, okay, I'm going to spend this much money per year on this particular treatment, and each exacerbation is an episode, right? And it has an impact on quality of life for a period of time. That's a known. Any consideration when you were putting this together to think about it like that, or am I off? Like, is it a wacky way to calculate? To really think about this in a different way. And I'm not sure it changes my conclusion, but I think without sort of like maybe more sensitive quality of life data, I don't know, maybe maybe that's another way that I can kind of process this.
Yeah, and Eric, you can think about it from the total cost table and the non-intervention costs. So we were avoiding 60,000, but that's over a lifetime. And then if you compare to the increase in the cost based on the placeholder price, there's no way you really can overcome that from avoiding exacerbations. Now, in my personal opinion, we should be modeling the day-to-day symptoms of asthma, and it shouldn't necessarily just be based off of avoiding exacerbations. I think that's a really important point. But we include both in the model and allow for those cost offsets. You're not wrong in thinking about it. I think the challenge is cost per event estimates always exceed cost per quality adjusted life year or equal value of life year gained estimates. The reason being, we're not accumulating the benefits of the treatment over a lifetime. We're just basically saying you're avoiding an exacerbation, and by doing so, we're not giving the full benefit of Tezepelumab. We saw this really clearly. If you all remember the additive cardiovascular meeting, we actually were in person, and I remember seeing some of you, where the cost per MACE event avoided was much higher than the cost per quality adjusted life year estimate, because we were treating death and these events as one-time things, when in reality, there's a quality of life change. If you have a severe exacerbation, it adds up. There's an accumulative effect on somebody's quality of life, and that's what we're really trying to capture. So, but you're not wrong in thinking about that as another point of.
Well, just kudos to you and the team for like a solid analysis, clearly presented. Just want to thank that again. And then I think also this answer here that you provide, I'm glad you sort of put that into the record today. Thanks.
Thank you both, Eric and Brett. Kurt, I did see your hand up. I don't know if you have a question.
Yeah, I did have a question about slide 48. I wonder if we can go to that just quickly. My question was about those costs for the inputs. Are those static numbers, or have they been adjusted for inflation or other factors?
Yeah, so it's a really good question, and you just caught you just caught a mistake, Kurt. Thank you for doing it. There is uncertainty built around these estimates that I didn't mention. These are means for now, but in the model we actually have uncertainty around it. And you are correct that if the evidence was produced in 2017 or 2016 in terms of costs, we inflate to current 2021 or the most recent estimates that are available from the price index that ICER uses. So.
Okay, thanks.
Well, thank you. I'm not seeing any more hands up, but I did see some discussion in the chat. We still have a few minutes about different social determinant of health and the panel's certainty or lack of certainty about how that affects. I don't know if any of the Midwest CEPAC would like to comment on that and just make sure that it is part of the public discussion.
Well, just seeing that nobody else has commented, you know me, Reem, I'll comment on almost anything. I really want to give some uncertainty here, but as both David presented in his presentation and Brett in his, I can't get there. It's the bars, even at the far ends, are just so far above anything that's cost effective, and I guess the best I can get at is our clinical experts and our patient experts saying, I see a big improvement. I see something not captured in a validated, standardized, disease-specific quality of life metric, but that's not the science we have in front of us or the methods we have. And I don't know, unless we change things, that's what we have to go on.
I disagree. There is an improvement that's seen, and I think we're misinterpreting how to evaluate the role of these tools with regard to the MCID. You're seeing a substantial improvement. Yes, you're seeing improvement with placebo too. That's beyond what you'd expect. It's beyond the 0.5, but we see it beyond that, beyond whatever's seen with placebo. And I think it's very hard when you have subjective patient-reported outcomes and you're misutilizing that tool for quality of life.
I'm just going to respond to a methods situation. I mean, the standard metric for assessing effectiveness is looking at the change versus the comparator, not the change from baseline. I agree with you that MCIDs report change from baseline, but to assess effectiveness in all studies is to determine whether there is a meaningful difference, whether it's means, percents, et cetera, versus the comparator. Otherwise, we just don't do randomized trials.
Right. No, I agree. And for that outcome, it's not demonstrating it is statistically significantly different. It's just not meeting that MCID. But the purpose of these tools is not to measure across a population. It's within an individual. Do you improve by 0.5 or greater?
Well, I think I'm just going to put my methods hat on and now say this is really the beauty and the power of having a randomized controlled trial. When you have randomized controlled trial, because you are adjusting for all these prognostic and confounding factors in both arms equally, and you are really, you have the power. That's why it's great that we have those randomized trials to compare the intervention to another arm. Again, the point has been already mentioned. This highlights the importance of these co-interventions, if you may, in a trial where all the support that these patients are getting does make a difference. And it's going to be an important part of the care planning and management planning, but it doesn't really mean that we should accept that the placebo improvement minimizes that there is really not a huge difference between both arms. I think that is important to keep in mind.
I would agree with you, Reem, on that. And I think these changes that we're seeing in the Tezepelumab trial are fairly comparable to what's been seen, with other biologic medications, including dupilumab. But, what struck me about Brett's presentation, or maybe in the presentation before, was the issue of managing long-term the adverse events related to chronic oral corticosteroid use, or not chronic, recurrent oral corticosteroid use. And if people are having 2 to 3 bursts a year, which I think most of us agree that that's about it, and you're getting a 2/3 reduction in that we know good data now over the last few years showing that even a gram of lifetime use results in an increased odds ratio for osteoporosis and cardiovascular disease and diabetes. And this population that we're looking at, could very well be using, maybe close to that in a year or a couple of years. So when you look at the kind of reduction, and it's not just pertinent to Tezepelumab, but many of these other drugs, and I'll speak in a moment why I think Tezepelumab is importantly different. That adds up over, these people are in their 20s or 30s. We don't know when they're going to stop having asthma, probably never, unless there's a remittive therapy up the pipeline. But what makes, this drug different that we haven't talked about much is in the non-type 2 population, we don't really have much to offer these patients. And as we saw from the baseline demographics, the non-type 2 patients at baseline had as many exacerbations in the prior year as did the type 2. So in view that we don't have much to offer these people at the present time, and that Tezepelumab had about a 40% reduction in exacerbations, that does present a very unique aspect, to this drug. And it's the first biologic that really does this. So I agree with everything everyone has said about the difficulties in using our current instruments for quality of life, which don't necessarily reflect what we see in the clinic, but it's all we have. But I think it's this aspect that of a non-type 2 population. And I think compounding that is that people seem to move in and out of these so-called, pathophysiologic categories. And I've written a couple papers on this, and I'm sure Mike's been involved as well, where when you follow these people over a year, they can move well below 150, they can move well above 300. So the question becomes, is that part of the failure of existing therapies, is because they are more restricted to a type 2 or allergic phenotype? Is that a problem? So from my perspective as a clinician, that's just something I wanted to add.
Oh, thank you, Dr. Curran. Again, very important point, highlighting that potentially maybe for us to consider those long-term consequences of steroids therapy is key. And I see Brett has his.
Yeah, I just wanted to respond that we do actually include the impact, both in terms of adverse events that are quite significant every year, as well as impact on quality of life. I think that the issue, Dr. Corn, why it didn't show up is we really only had about 10% from the trials that were on chronic OCS. So if our population was that 9.6%, that impact would have been, more pronounced. But I think it's not that we didn't include it. It was in the model. It's just that representative patient group wasn't 100%, if that makes sense.
It does. No, thank you for that. But I was wondering, how does the model weight people with recurrent courses of oral corticosteroids? So let's say over a 10-year period, they've had 30 bursts, which add up to 150 to 300 days of steroid use. And we know that, the data is now there suggesting that there's a definite statistically increased risk of expensive long-term adverse events.
Yeah, it's a good question. We actually spent quite a bit of time up front in this review looking for the relationship of that evidence over time, where if you increase the dosing, what's the increase in the adverse event? And there is evidence on it, but it's quite difficult to estimate in severe asthma as it would flow into the model, surprisingly. We found information in lupus that was probably the most helpful, but we didn't feel confident in applying a separate disease area to asthma. But you're right, and that is actually sort of a data gap that I feel like we really need to focus on. In terms of long-term evidence, there's a lot on 1 to 3 years that stratifies by dose, but we felt like modeling anything above 5 milligrams was, we really should just focus on that as a major impact. But you make a good point.
Thank you.
Okay, excellent. And these are really important recommendations for